And so with your permission, I would like to welcome all of you, all panelists, dignitaries, and respected nephrologists from the Cochin and the different parts of India. I'm Dr. Mangesh Bhalera, Head of Medical Affairs, RPG Life Sciences. I also welcome doctors who are listening to us from Nepal and Myanmar. Thank you for joining us today for the today's webinar on treatment of osteoporosis in CKD and renal transplant. So before we could start session, it's our immense pleasure to welcome our respected moderator before he could introduce our speaker and set the objectives of the program. So our today's moderator is Dr. Georgy K Nainan, sir. Thank you for joining us, sir, today. Welcome you. Dr. Georgy, sir, he's a senior nephrologist at Cochin and is a senior consultant nephrologist, and he has been contributing in the field of nephrology more than 40 years. He is a founder member of Nephrology Extracorporeal Group, and with his immense experience, he has been keynote speaker for many conferences, CMEs. He has chaired many sessions as a panelist on many subjects related to nephrology. One more thing, he is touching lives and many souls through his inspirational talks. He is motivational speaker too, and he's motivating the crowd like students, executives from pharmas and the other healthcare professionals. So, sir, with this introduction, I would like to hand over today's proceeding to you. Over to Dr. Georgy, sir. Thank you so much.
Thank you, Dr. Mangesh. At the very outset, thank RPG Life Science, in particular Deepu and Rohan and yourself for bringing up this topic and so that we can discuss many aspects of osteoporosis today. So, my dear friends in the speaker pool, invited guests from Kochi, from Kerala, as well as from outside Kerala in India, it is my immense pleasure to introduce the speaker as well as the subject. Osteoporosis is gaining a lot of importance, whether it is age-related, postmenopausal in females, steroid-related in CKD treatment, CKD-related MBD. So we have a lot of a wide spectrum for osteoporosis. So we have an update on the treatment, recent molecules which have come in the treatment of osteoporosis. And we'll have a talk by Dr. Jose Paul, and then we'll have discussion about vitamin D, calcium, CKD, osteoporosis in CKD in particular, and finally the preventive steps. Dr. Jose Paul is president of the ACN, very good friend of mine and everybody, and he's a very active member of this extracorporeal group. And he's a senior consultant nephrologist at the Lisie Hospital. He's a good speaker with a flair to talk on newer molecules. So he's the most apt person to talk on two molecules today introduced by RPG Life Sciences, Demri, Denosumab, and TPT20. So with this few words, let me welcome Jose Paul to take over and to deliver your talk. Jose Paul, please.
Good evening, everyone. Thank you, sir, and thank you, RPG Life Sciences, for giving me an opportunity to speak on this topic. So, osteoporosis, I'll be speaking on osteoporosis in CKD, and I'll be discussing the subject as 3 case scenarios. So, the first case scenario will discuss a patient with osteoporosis and chronic kidney disease, KDIGO stage from G1 to G3B. The second case will be a case of osteoporosis in a patient on dialysis, that is CKD stage 5. And the last one is a occurrence of osteoporosis in a renal allograft recipient. So I'm just going to the case. So the case one is an elderly lady who presented with back pain. So this is a 70-year-old lady, postmenopausal and diabetic since 25 years, hypertensive with dyslipidemia. a vasculopath with coronary artery disease and retinopathy with a history of chronic kidney disease diagnosed around 2 years. She presents to the outpatient for a regular checkup of renal functions. And in the outpatient, she complains of lower backache, and she has been having this dull ache since 2 days, no radicular pain, and she gives a history of fall in the bathroom around 3 days back. And on examination, she is a tall, thin-built lady with a body mass index of around 24 kilogram per meter square. The vitals are okay, no edema, mild tenderness over the L1 spine. Neurological examination is unremarkable, no sensory or motor deficits in the lower limbs. So she had a hemoglobin, labs was reported as a hemoglobin of 12.4. The creatinine was around 1.6. eGFR, according to the CKD EPI, was around 34 ml per minute. So putting her into CKD G3B. So this X-ray that has been taken. So you can clearly see a fractured vertebra, L1 vertebra, with the normal bones appearing. So when you get a fracture like this, you'll have to think about the differential diagnosis of vertebral fractures. So the first thing that comes into mind is an osteoporotic fragility fracture. Then, of course, in the elderly, you think about myeloma, metastasis, then rare conditions like all these Schmall's nodules, sickle cell disease, Gaucher's disease, etc. Very rare conditions. So the approach is something like that of a pathological or a fragility fracture. Now I'm putting the word fragility fracture. So the fragility fracture is defined as a trauma-associated fracture when one falls from one's own height. That is a very trivial trauma, enough to fracture the bones. And this condition is known as a fragility fracture. So it can involve any bones of the body, but usually the finger bones, the toe bones, the face, the skull, all these are excluded from fragility fractures. So it is a low energy fracture. So you have to think about tumors, metabolic diseases like osteoporosis, Page's disease, renal osteodystrophy, osteomalacia, or rickets. Then osteoporosis can be primary or secondary. Primary osteoporosis, especially in a postmenopausal elderly lady. Then secondary causes of osteoporosis are there, like those involving the bone, or those involving the metabolism of calcium or the phosphorus. So investigations in this lady revealed a corrected calcium of about 8.6. The phosphate was reported as 4. The PTH was 65. The vitamin D was normal, and no M band on electrophoresis. And the evaluation of the thyroid, breast, lung, and the gastrointestinal tracts were normal. So the patient was taken for a DEXA scan. So DEXA scan is a primary modality of evaluation of osteoporosis. So osteoporosis, you look at the bone mineral density. So you're looking at the bone mineral density primarily in the two sides, that is a lumbar spine as well as a hip specifically the femoral neck. So you're assessing the bone mineral density. So you're placing the patient in an X-ray machine, and the X-ray delivers two X-ray beams of varying intensity, varying energy intensity. And by calculating the difference between the two energy intensities and calculating the pixels obtained, we get an idea about the density of the bone in per meter square. So this is not a volumetric assessment, it is an aerial assessment of bone density. Then you calculate two scores, which is known as a T-score and the Z-score. So this is what is done in a DEXA scan. Now this patient had so this is a this red line, thick red line, represents the bone mineral density of the patient, and these are standard deviations from the patient's bone mineral density reading. So this patient, if the patient's age is 60, this is a red line, and you have one standard deviation here and one standard deviation here. And to diagnose osteoporosis, you will have to compare this to the bone mineral density of a 20-year-old person, young adult, healthy, with the same gender and the race. So that is what you compare to. So this patient had around just over one standard deviation lower bone mineral density from the patient's mean. And when you compare it to the young adult, it is about 2.5 standard deviations below. So this is what is known as a T-score. So if the T-score is less than minus 2.5, it is diagnostic of osteoporosis. So this is what is known as a T-score. Now there is another score which is known as a Z-score. So Z score is a standard deviation that is applied to the patient's own, if you compare the mean to the patient's, to a population of the patient's age, that is known as a Z score. But when you compare it to that of the young, a healthy adult individual of around 20 years, it is known as a T score. So when the T score of the patient is less than minus 2.5, you call it as osteoporosis. So this is how you make a diagnosis of osteoporosis in postmenopausal women. So if the patient had a fragility fracture of the spine, hip, wrist, proximal humerus, or the pelvis, if fragility fracture itself, without when you rule out all the other causes of pathological bone fractures, it by itself is osteoporosis. But often you require a DEXA score to conclusively conclude that it is osteoporosis. And but what will you do when the score is between -1 and -2.5? Here, if you take the whole population of the patients, like the postmenopausal women, the majority of the people will fall under this group, and this group is known as osteopenic patients. So osteopenia is defined as a T score on DEXA scan somewhere between -1 and -2.5. Again, these patients are also prone for osteoporosis. So you have to calculate the risk of these patients in the osteopenic group developing fractures by using another tool known as a FRAX score. So this is a fragility fracture risk assessment score where we put in a lot of variables. It is available as online. And this, what it does is that it calculates the 10-year risk of developing a hip fracture or any major osteoporotic fracture. So if you put these osteopenic patients and calculate the FRAX score, and if the score is more than 20% for any major osteoporotic fragility fracture, or more than 3%, especially with respect to hip fractures, again, you call it as osteoporosis. So this is a group, this is how you make a diagnosis of osteoporosis. So osteoporosis is diagnosed in these patients by these DEXA scan as well as a FRAX score. Now I'll skip this slide. So we have to know the pathogenesis of osteoporosis to fully understand how we treat osteoporosis. Now, bone is a very dynamic tissue, and it receives around 10% of the cardiac output. And you will be surprised to know that our whole skeleton is actually replaced once every 9 to 10 years. So it maintains the structural integrity of our skeleton. This is remarkable because when you construct a house or a bridge made up of concrete and cement, hardly it lasts for 40 or 50 years. But the skeleton, being a living tissue, and it undergoes constant remodeling, and it survives for maybe, if your lifespan is more than 90 years, it still maintains its structural integrity. And this is by a process known as bone remodeling. So bone remodeling is essential because our constant day-to-day stress will lead to microfractures in the bone, and this has to be repaired then and there itself. So this whole process is known as bone remodeling. So bone remodeling starts with the activation of what is known as an osteoclast. So the whole unit is known as a bone remodeling unit. So the bone remodeling unit consists of osteoclast as well as osteoblasts. So the initial trigger, so this is a dead bone, which is an old dead bone, which has undergone a fracture. And this has to be replaced by, this has to be scalloped or scooped out by osteoclast. And for the osteoclast to get activated, so the osteoclast is derived from the hematopoietic progenitor. And this osteoblast undergoes a series of commitments. And this is mediated by the macrophage colony stimulating factor. And one of the most important things is what is known as a rank ligand. And this rank ligand is actually produced by the osteoblast. So the osteoblast produces a rank ligand, and the rank ligand binds to a mononuclear osteoclast, and this mononuclear osteoclast has rank receptors on this surface. The rank ligand binds to rank on the mononuclear osteoclast. Many mononuclear osteoclasts fuse together to form a quiescent osteoclast. Again, the rank ligand as well as interleukin-1 activates this quiet osteoclast into an active osteoclast, and the active osteoclast is multinuclear. So the multinuclear osteoclast comes here and starts destroying the scalloping and resorbing the old dead bone. So this is a these are the active osteoclasts scalloping and reabsorbing the old dead bone. And once the bone has been removed, completely removed by the osteoclast, the osteoblasts swing into action. Now, the osteoblast is derived from a mesenchymal cell, and the osteoblast undergoes differentiation by bone morphogenic proteins and trunks too, and it becomes an active osteoblast. And the active osteoblast has two main functions. So it secretes osteoid. Osteoid is the collagen non-mineral component of the bone. So it is made up of type 1 collagen, osteocalcin, lot of proteins are there, and these proteins are laid down by this osteoblast. So the osteoid is laid out by the osteoblast, and once the osteoblast also gets embedded within the layers of the osteoid, and once it gets embedded within the osteoid, it transforms itself into an osteocyte. So this is a osteocyte which is derived from the osteoblast, and the bone is remodeled. So this is a whole process of remodeling. So it is interesting to note that these cells, these osteoblasts, which are transformed into the osteocytes, these are the master regulators of bone remodeling. So it regulates the activity of the osteoclast as well as the osteoblast, and sends signals to the osteoclast as well as osteoblast, and coordinates the activity of the osteoclast as well as osteoblast. So this is a whole process of bone remodeling. So the osteoclast comes and scallops and takes up all the dead bone. This is followed by osteoblastic activity. It lays down the osteoid, and once the osteoid is laid down, the osteoblast starts secreting the calcium, phosphate, and mineralization of the bone. This is a whole process of bone remodeling. Now, this bone remodeling is under the control of various factors. So, what are the factors which causes bone resorption? Bone resorption means that the osteoclast gets activated. So the bone resorption is actually mediated by the rank. So the osteoblast secretes this yellow things. This yellow biomarker is a rank ligand, and this rank ligand binds to the rank receptor. The rank receptor is found on the osteoclast precursors, and this osteoclast precursors gets converted into multinucleated osteoclast, and the multinucleated osteoclast gets activated again by the interaction of rank ligand and the rank. And the activated osteoblast starts bone resorption. And the pro-resorptive factors are vitamin D, PTH, lot of things are there. Steroids are also included here. Now, once the bone has been resorbed, the osteoblast has to do its work. So for the osteoblast to do its work, you have to inhibit the osteoclast. So what the osteoblast does is it secretes what is known as osteoprotein. And osteoprotein is a soluble protein which binds to rank ligand. So this red-colored, Y-shaped red-colored things are osteoproteins, and the osteoproteins binds to rank ligand, and it prevents the binding of the rank ligand to the rank receptors. So the osteoclast becomes inactive, and it undergoes apoptosis and it dies. So this anabolic effect is mediated by estrogens, calcitonin, and a lot of other cytokines. So this is a mechanism of action in a bird's eye view of all the drugs which are used, main drugs which are used in osteoporosis. So the red ones are the anti-resorptive agents. The green one is an anabolic one. So the red elements are the bisphosphonates, then calcitonin and denosumab. Denosumab works something like an osteoprotein. It binds to rank ligand, and it prevents the interaction with the rank ligand with the rank receptor. Now the bisphosphonates gets absorbed into the osteoclast and inhibits osteoclastic activity. Calcitonin has direct receptors on the osteoclast and inhibits the activity of the osteoclast. PTH will come to it later. So that how do you make a diagnosis of osteoporosis in chronic kidney disease stage 1 to 3? So the first and the foremost cardinal rule in making a diagnosis of osteoporosis in a patient with chronic kidney disease is that we have to rule out chronic kidney disease and mineral and bone disease. So mineral and bone disease has to be ruled out by biochemical tests, and it is extremely difficult to diagnose osteoporosis in setting of chronic kidney disease MBD. Even if you do a bone marrow biopsy, it is difficult because there are no criteria which tells you the histomorphometry of osteoporosis in a setting of chronic kidney disease, CKD MPD. Now, the DEXA scan and the FRAX score can be applied to a patient with CKD. And this is in essential the nutshell of how you make a diagnosis of osteoporosis in a patient with CKD stage 1 to 3. So if a T-score is less than -2.5, or if there is a presence of fragility fracture, provided there is no evidence of CKD MPD. The whole goal of diagnostic evaluation is to distinguish osteoporosis from other elements of CKD MPD, especially adenemic bone disease. As you already know, adenemic disease is a condition which is characterized by low bone turnover. So there is very little osteoid, and the bones are easily fragile and they fracture quite easily. So how do you make an assessment by lab parameters of osteoporosis in setting of CKD stage 1 to 3? So you have to measure the calcium, phosphorus, parathyroid hormone, 25-hydroxyvitamin D, and alkaline phosphatase. If all the parameters are normal, you generally rule out CKD MPD. And any abnormality, you make a diagnosis of chronic kidney disease, mineral and bone disease, and you have to treat CKD MPD first, then only you think about treating osteoporosis. And the treatment is using the same medications as used in the general population. So the first thing that you look for an osteoporotic fracture is whether there are any modified factors or non-modified risk factors. So certain modified risk factors are there, like cigarette smoking, estrogen deficiency, poor nutrition, especially low calcium and vitamin D intake, alcoholism, impaired eyesight, leading to recurrent falls, inadequate physical activity. All these are modifiable risk factors. Then there are certain non-modifiable risk factors like white race, advanced age, female gender, dementia, and history of fracture as an adult. Then there are it is now thought to be genetically mediated also. That is, certain people are genetically mediated to develop osteoporosis, and they localize the chromosome localization to chromosome 11. Now, how do you treat osteoporosis? So first, an osteoporotic fracture has to be treated. Then you will have to think about risk factor reduction. Then you will have to think about nutritional measures, exercise, and pharmacological measures. So nutritional treatment, calcium is often supplemented. The main goal is to make the daily calcium load to about 1000 milligram per day. And this 1000 milligram should be elemental calcium. So the main source should be the diet, and the dietary supplements are added to bring the daily calcium load to around 1000 milligram per day. And vitamin D, the target vitamin D should be 25-hydroxyvitamin D level should be more than 30 nanogram. And the daily requirement is about 800 to 1000 international units per day. It all depends upon the race and ethnicity and the amount of sun exposure that you receive. Then if you are planning exercise, you have to advise on load-bearing exercises. Then pharmacological therapies, what are the indications? So the indications of giving a pharmacological therapy almost is similar to that with a patient without CKD MPD. So one is a fragility fracture with osteoporosis, a T-score less than -2.5. Then a fragility fracture with a bone mineral BMD within the osteopenic range, that is between -1 and -2.5. And a FRAX score which tells you at 10 years there is a more than 20% fracture risk or a more than 3% hip fracture risk. These are the indications for starting therapy. Now, the pharmacological therapies can be broadly classified into two categories, as I already told. One is anti-resorptive therapies, other is anabolic agents. Now, the anti-resorptive therapies, you can try hormones. If the patient has a early menopause or ovarian failure, you can try estrogen therapy or selective estrogen receptor modulators. Then the mainstay is one of the mainstay and the first line drugs is bisphosphonates. Then you have denosumab and calcitonin. Then anabolic agents, we have the new drug, which is teriparatide, then abaloparatide, and romosozumab. These are the anabolic agents which are used in the treatment of osteoporosis. Now, estrogens. How do estrogens act? Estrogens act mainly by means of, they inhibit osteoclastic activity by interacting through osteoblasts. Now, the estrogens have receptors known as estrogen receptor alpha in osteoblasts. They decrease rank ligand production and increase WNT signaling. Both of these decrease osteoclastic activity and increases osteoblastic activity. Whenever there is an increase in the WNT signaling, the osteoblastic activity increases. Whenever there is a decrease in the rank ligand production, it decreases osteoclastic activity. So there will be increased bone formation and decreased bone resorption, and the total bone mass increases. Then there is selective estrogen receptor modulators. Now the difference from the estrogen in this selective estrogen receptor modulators are each drug has got a unique drug receptor interaction, which leads to a unique conformational change. So it produces antagonism at certain target sites, and it produces agonism at certain target receptor sites. So these are selective estrogen receptor modulators. Now estrogens, they have found to decrease up to 50% of osteoporosis related fracture, including hip. They decrease the coronary artery disease, but however they increase incidence of carcinoma of breast, stroke, and deep vein thrombosis. So not quite popular unless there is a premature ovarian failure or such conditions. Now selective estrogen receptor modulators, tamoxifen is one drug which decreases the bone turnover and loss, but it is not FDA approved for the treatment of osteoporosis. Then you have raloxifene, which has a decreased efficacy when compared to estrogen, decreases the incidence of carcinoma breast, but increases the C endometrium and increases the risk of deep vein thrombosis. So the estrogens as well as selective estrogen receptor modulators are associated with the major disadvantages. Now, the main class of the drugs which are still used in the first-line treatment of osteoporosis is bisphosphonates. Now, bisphosphonates are again anti-resorptive agents. They are the mainstay of treatment of osteoporosis. They are actually pyrophosphate analogs. So these pyrophosphate analogs are taken up by the osteoclast, which is a bone resorbing cell. And this, what it does to the osteoclast, it decreases the osteoclastic activity and promotes the osteoclastic apoptosis. So the osteoclast becomes just silent. So there is no bone resorption. So it is a powerful anti-resorptive agent. Now there are a lot of drugs like alendronate, zoledronic acid. All these drugs are used in the treatment of steroid-induced osteoporosis. Risontrate and zoledronic acid are used in the prevention of osteoporosis. They can be given by the oral route or intravenous route. And one of the most important things that you have to check before starting a bisphosphonate is that you have to take a careful history to rule out any esophageal lesion, like esophageal dysmotility, peptic ulcer disease, especially esophageal ulcer. These things have to be ruled out. And you have to administer the drug after an overnight fast, because rate of absorption from the stomach is much less. And you have to ask the patient to sit upright for nearly 1 hour after intake of bisphosphonates. And it is found to decrease the vertebral and non-vertebral fractures. This is bisphosphonates. And this is one of the two major complications of bisphosphonates. One is osteonecrosis of the jaw. Osteonecrosis of the jaw, you are seeing the bone here. This is a jawbone which is visualized. What happens is that when you give bisphosphonates, the normal rate of bone remodeling is lost. So the remodeling doesn't happen as efficiently as previously. So the bone resorption is inhibited. You can get an osteonecrosis of the jaw, and this bone will be exposed. This is a painless condition, and it is very difficult to treat and very difficult to heal. So this is osteonecrosis of the jaw. So before starting bisphosphonates, it's usually recommended that you send the patient to the dentist, get the teeth sorted out, rule out any focus of infection. And one of the advice to the patient should be that the patient should visit the dentist regularly and report any lesions like this happening. And all dental implants, everything should be done with caution once the patient is on bisphosphonates. Then another side effect with the use of bisphosphonates is a typical fracture of the femur. So the typical fractures of the femur happens at the femoral neck and the intertrochanteric fractures. So these are the classical sites of femoral fracture. However, in a patient with who is on bisphosphonates, you can have subtrochanteric fracture and fracture of the femoral shaft. So these are atypical fractures of the femur. This can also happen with bisphosphonates. Then the other drug which is used in the treatment of osteoporosis is denosumab. So denosumab is a fully humanized monoclonal antibodies against rank ligand. So it is marketed as Denbury by RPG. So it is packed as a 60 milligram per ml injection. So it is given twice yearly dosage, subcutaneous. And the major advantage of denosumab or bisphosphonates is that it doesn't have any renal clearance. So you can safely use in patients with the chronic kidney disease. So it decreases the vertebral and non-vertebral fractures. And the main problem is it can have hypersensitivity reactions like urticaria, allergic reactions, rashes, eczema, and another complication is hypocalcemia. And the other problem with the denosumab is that once you stop denosumab, there will be the osteoclasts which have been kept quiet by the denosumab spring into action, and there can be severe rebound bone resorption. So before you stop denosumab, you have to think about starting the patient on bisphosphonates to prevent bone resorption. Now, the other drug which can be used is calcitonin. It is a treatment of hypercalcemia and Paget's disease. It is used. The major disadvantage is that it decreases a vertebral fracture. It can have nausea and facial flushing, and it increases the incidence of malignancy when it is used as a long term. So, not generally recommended as an anti-resorptive agent. Then the other new drug which has come for the treatment of osteoporosis is teriparatide. It is a recombinant form of parathyroid hormone, which incorporates the first 1 to 34 amino acids, which is an active part of the PTH molecule. And the action of the PTH is quite interesting, because if you have a chronic PTH exposure, the net effect is bone resorption, as we see in patients with secondary hyperparathyroidism in our dialysis population. But when you give parathyroid hormone as an acute intermittent doses, then it favors a bone remodeling. So it activates the osteoblast by binding on the PTH1 receptor on the osteoblast, and it increases the osteoblastic activity, and it increases the production of rank, and it increases the osteoclastic activity as well. So the bone is stimulated, really stimulated, and you can have an increased bone turnover. The osteoblast gets activated as well as the osteoclast gets activated. But when you give it as an acute intermittent dosing, the overall effect is bone formation will be more than bone resorption. And it decreases the vertebral and non-vertebral fractures, and it can be used as a sequential therapy where denosumab. So first you build up the bone by giving teriparatide, then you prevent bone resorption by giving denosumab. This is the idea behind the sequential therapy. Some people have advised combination therapy, but in general, the authorities in the field avoid combination therapy because this denosumab will inhibit the osteoclastic, it decreases the resorptive actions of teriparatide. So generally, a sequential therapy is advised. So teriparatide is given as 20 microgram daily subQ for a mean of 18 months. FDA has restricted its use for up to 2 years. So it is marketed as TPT20 by RPG, teriparatide injection 600 microgram per 2.4 ml, and 20 microgram. This lasts for about approximately 28 days, daily subQ injections. And some studies have shown that there is an increased risk of osteosarcoma. So this is contraindicated in patients who have undergone external beam. Then it is contraindicated in patients with a history of bone tumors. So this is regarding teriparatide. So teriparatide, there are trials like when they give teriparatide 20 microgram given subcutaneously for 18 months, the fracture rate decreased from 100 to 35% in the teriparatide treated group. So there are a lot of papers which support the use of teriparatide in the treatment of severe osteoporosis. Now this is a paper which tells about the sequential 2-year data of denosumab and teriparatide administration post-menopausal women. So they found that it increases the bone mineral density more than therapy with either medication alone. So there are a lot of papers which support this sequential therapy. Now we are coming to the case 2 scenario, that is a dialysis patient with a fragility fracture. Now the things become very murky, very complicated, very difficult to interpret. Now this is a 72-year-old male, diabetic, on thrice-weekly maintenance dialysis, presents to the ER with complaints of pain in the right hip fall in the bathroom. So he has a good vascular access with a right radial AV fistula, thrice-weekly dialysis, compliant with the diet and medications. So the calcium is 8.5. All the parameters are within normal limits according to her CKD status, and the PTH is in a good range, and the vitamin D replete. Now, evaluation of osteoporosis in CKD stage 4 to 5 again, you have to measure the calcium phosphate PTH 25 hydroxy vitamin D as you do with the CKD stage 1 to 3. But in addition, it is recommended that you do a bone specific alkaline phosphatase. So this is found to be the marker with the highest value in discriminating bone turnover in CKD. And this particular bone specific alkaline phosphatase is produced by the osteoblasts, and a value of more than 33 international units per ml rules out an endemic bone disease. And if you use, this is especially if you use a combined value of PTH. So if the PTH is more than 350 and the bone specific alkaline phosphatase is more than 33, it virtually rules out the dynamic bone disease. And it is a definitive diagnostic method to rule out CKD MPD in stage G4 to G5. The best method to rule out CKD MPD is a bone histomorphometry. But unfortunately, this is a very cumbersome method. You need tetracycline labeling, and there are few pathologists who are good at interpreting a bone histomorphometry. And the cardinal rule in any CKD patient is that you don't treat osteoporosis if there is CKD MPD. Now, how do you manage an osteoporosis in CKD G4 to G5, that is with a GFR less than 30? So if there is a presence of fragility fracture, then only treat the patient. If there is no fragility fracture, no treatment. So if there is a fragility fracture, treat osteoporosis only if there is no feature of chronic kidney disease, mineral and bone disease, or renal osteodystrophy. And if the GFR is between 15 to 30, you have to treat osteoporosis. It is left up to the clinician as well as the supporting environment of the physician whether a bone biopsy can be done. And if the GFR is less than 50, ideally requires a bone biopsy. And you have to treat only if the risk of mortality from another fragility fracture is high. So the treatment is really reserved. And ideally, you require a bone biopsy. And if you look at the KDIGO guidelines, again, they are quite vague about what happens with a CKD stage 4 to stage 5. There are no clear-cut guidelines or no society recommendations. Now, which drugs can be used when eGFR is less than 30? Bisphosphonates, the FDA tells you shouldn't use bisphosphonates when the GFR is less than 35 ml per minute because they are cleared by the kidney by glomerular filtration and tubular secretion. However, they are used by experts in the field by modifying the dose interval and duration. And all the up-to-date experts recommend that you send it to a person who is well-adapted, trained in the use of bisphosphonates when the GFR is in the less than 35. And the anti-receptive molecule which can be tried in such a situation is denosumab. The advantage is that it is not cleared by the kidney. However, there is a risk of hypocalcemia and doubtful vascular calcification. Now, in a adenic bone disease, theoretically teriparatide can be used, but currently there are only few case reports, and there is no society guidelines with regards to the use of teriparatide in adenic bone disease. But however, if you search the literature, you will find out there are certain clinical reports like treatment of adenic bone disease in a hemodialysis patients with teriparatide. Now, I'll coming to the last case scenario, that is a renal allograft recipient with a fragility fracture. So this is a 45-year-old female patient who underwent a living transplant and presents with a fragility fracture with a stable graft functions, normal for calcium phosphate and vitamin D levels. So post-transplant osteoporosis, causes of osteoporosis are many, which include steroids, calcineurin inhibitors, and persistent hyperparathyroidism. There are a lot of risk factors, and all transplant candidates should be ideally screened for PTH, vitamin D, DEXA, X-ray thoracic and lumbar spine as a part of pre-transplant screening. And once the graft functions are stabilized, you have to repeat PTH, vitamin D, calcium, phosphate, bone-specific alkaline phosphatase, and look for markers of bone resorption like C-terminal telopeptide. And if the conditions which predispose to high risk of fractures are osteoporosis with a T-score less than -2.5, osteopenia with a T-score somewhere with a history of fragility fracture. Now, there are two aspects of it. One is prevention of post-transplant osteoporosis. So all patients with a normal bone mineral density, you have to use the steroid at a lowest dose. Lifestyle changes should be advocated. You have to treat with calcium and vitamin D if the calcium is normal, and you have to treat persistent hyperparathyroidism. High-risk patients, you should assess bone turnover by looking at the C-terminal telopeptide and bone-specific alkaline phosphatase. And if it is a low bone turnover, theoretically you can consider teriparatide, no low bone turnover, then you can use oral bisphosphonates or denosumab, depending upon eGFR. Now, how do you treat post-transplant osteoporosis? There are 3 steps. Step 1 is lifestyle changes with calcium and vitamin D supplementation. The most important step is you have to rule out persistent hyperparathyroidism, which is defined as more than 130 picogram per ml. You have to treat that. And if there is no hyperparathyroidism and the patient has got a low turnover or not, you have to check PTH and bone-specific alkaline phosphatase. And again, the treatment of low bone turnover, doubtful the use of teriparatide. No low bone turnover, you can use bisphosphonates or denosumab. So the key take-home points is treatment of osteoporosis in CKD G1 to 3B is same as in general population. And CKD is stage 4 to 5, treat only if there is a fragility fracture. Rule out adenoid bone disease and CKD MBD by using surrogate markers of bone biopsy like PTH and bone-specific alkaline phosphatase. And post-transplant osteoporosis, you have to screen. Preventive measures are important, and always you have to rule out persistent hyperparathyroidism. Thank you.
Thank you very much, Dr. Jose Paul. It's a very vast topic, and in the last 40 minutes or so, you have covered the pathophysiology, spoke about the T-score, result score in the DEXA scan, and anti-resorptive anabolic, 2 good agents which RPG has introduced and we are discussing today. And also you test upon bisphonate, which had been the mainstay for people with good GFR. So now we will concentrate on the discussion initial part on the topics which Jose had not covered because of the lack of time. So to start with, we'll ask Dr. Vilesh, the opening batsman, vitamin D levels. How does it help the clinician to decide therapy in CKD or even other?
Yeah, so vitamin D levels, which we look for is mainly, as Jose mentioned, 25 hydroxy vitamin D levels. And there are many methods for the same. The protein binding method, liquid chromatography methods. But what we radioimmunoassays, but what we commonly use now is liquid chromatography / mass spectrometry method. It gives you a value that it mentions that if it is less than 20, you are deficient. 20 to 30, you have vitamin D insufficiency, and more than 30, they say it's quite adequate. So as Jose mentioned, when you look for osteoporosis, we look for the levels of vitamin D levels. At the same time, you look for other surrogate markers along with it, where we have 24-hour urinary calcium is low, your alkaline phosphatase is normal to high, your serum PTH is normal to high, and at the same time, looking at the vitamin D levels, you can replace it at a weekly basis of supplementing vitamin D. Vitamin D is a fat-soluble vitamin, so definitely we have to, so if it is given with anything with high fat content, it is well absorbed. It can be given when patients are on, suppose on Ryle's tube or other feeding methods, you should use morally powder forms, and when it is otherwise, you can both oil as well as powder forms allowed. So that is what I feel, sir.
Yeah, thank you very much. And there are different types of vitamin Ds available in the market. Can Jyotipriya enlighten us about the good vitamin D, the active vitamin D, which we all use in chronic kidney disease? Jyotipriya, please.
Thank you, sir. And thanks for that wonderful presentation. So regarding the forms of vitamin D and its usage in CKD, first of all, we know how the vitamin D is formed in the body. We have main sources like sunlight as well as dietary source. So in sunlight, what happens? The 7-dehydrocholesterol is converted to pre-vitamin D, which is isomerized to active vitamin D. But that active process will have 2 steps. One, the 25 hydroxylation that happens in the liver, and subsequently the 1-alpha hydroxylase action in the kidney and converting to 125 dihydroxy vitamin D, which is the final active form. So what we have to understand is, see, this 1-alpha hydroxylase is not just present in the kidney. There are extra renal sites also. So if you ask the exact form of vitamin D in CKD, actually we can give both calcitriol and the natural vitamin D, that 60,000 unit, both can be given, especially in the early stages where we can use the advantage of the extra renal conversion of 25 hydroxy vitamin D to the active form. So second thing, this is more physiological. So since it is more physiological, the body will convert according to the need of the physiological needs, so that the over dosage of calcitriol and pushing the patient to a dynamic bone disease and vascular calcification will not happen. So if you take CKD is not giving a clear-cut eGFR where we have to use calcitriol, where we have to use the natural vitamin D. So there are no randomized controlled trials exactly saying regarding the role each eGFR cutoff as well. So in clinical practice, what we can do in early stages, we can go for a combination of 125 hydroxy, that calcitriol, as well as the natural vitamin D, the 60,000 unit. And as the stage of eGFR, as the CKD advances, we can increase the quantity or the dosage of calcitriol. And second, there are so many recent studies. We have made 3 recent studies which came in the last 3 years, analyzing the role of the 25-hydroxy vitamin D in dialysis patients. So there was a study published in JASN where around 158 patients have been studied, and they have found that even in dialysis patient, the conversion from 25-hydroxy to 125-hydroxy do happen predominantly in the extrarenal side. So we need more randomized studies to find the exact efficiency of the natural vitamin D in CKD patients. So till that, we can use both combination, which might be helpful in preventing the pushing of patient to vascular calcification and dynamic bone disease.
Thank you very much, Jyoti Priya. Now, we use steroid for many glomerular disease, nephrotic syndrome, glomerular lesions. And so steroid had been a main cause of osteoporosis in addition to other gender and age-related problem. Now, Sangeeta, what is your opinion on this steroid? How much is it, and what is your take on that?
Hi, sir. First of all, thank you, Joseph, for that wonderful and elaborate presentation. And coming to the question, steroids and osteoporosis. As we all know, steroids or glucocorticoids are one of the commonest secondary cause of osteoporosis. And it increases the risk of fractures, especially the vertebral fractures. And when you compare the postmenopausal osteoporosis to steroid-induced osteoporosis can occur even at a higher bone mineral density. And coming to the mechanism of action, sir has already elaborated. Steroids will affect has detrimental effects on the bone formation, turnover, and its integrity. It can affect the osteoblast, causing decrease in the bone formation. It can affect the osteoclast, causing impaired repair mechanisms. And then steroids will also decrease the calcium absorption from the GI tract, and it will increase the renal loss of calcium. And another important factor is the steroid myopathy, which can occur and make the patient more vulnerable to fractures, which are very important. And when we consider the treatment of this, we have to include both pharmacological and non-pharmacological therapy. And the pharmacological therapy, as is already mentioned, it's mainly the active, when you consider the preventive strategies, it's mainly the vitamin D, active forms of vitamin D, that is calcitriol and calcium. When it is combined, it's better than either when used alone. And then bisphosphonates are the main treatment of choice. And it's already mentioned, alendronate and risedronate can be given are the oral preparations, which are given weekly. And for patients who cannot tolerate oral bisphosphonates, there is then IV zoledronic acid is there. And and there are other options, teriparatide and denosumab. Denosumab was introduced for or approved for glucocorticoid-induced osteoporosis from 2018. But this zoledronic acid and teriparatide, it cannot be used in patients with severe renal insufficiency. But for denosumab, we can use even in patients with renal insufficiency. But when we consider this and the non-pharmacological aspects of steroid-induced osteoporosis, which is very important because the patient has to has to ensure that lifestyle modifications, and we have to ensure strength and weight exercises, which will improve the strength training, which is very important for such patients. And we also have to, in patients who have the risk of developing osteoporosis, like patients who are on long-term prednisolone, especially as sir has mentioned in nephrotic syndrome, where it is unavoidable. First and foremost, if it is possible, we have to reduce the duration and dose of steroids as far as possible. But if it is not, if it is unavoidable, we have to see we have to serially monitor the patient using the fracture risk assessment and bone mineral density, and institute the therapies to reduce the prevent or reduce the bone loss and decrease bone integrity as early as possible. Thank you, sir.
Thank you very much. We had been mentioned, Jose and Sangeeta mentioned about the bone density DEXA scan. John Abraham is here. So can you tell what are the limitations of DEXA scan in the diagnosis of osteoporosis? John.
Thank you, Joseph, for the detailed talk, sir. DEXA has its own advantages and disadvantages. DEXA is widely available and is a good test for bone quantity, and it is helpful in identifying persons with CKD who is at the highest risk of fracture. And DEXA is the best method for monitoring the changes in bone mineral density over time. And in therapeutic monitoring, serial DEXA can be used every 2 years, which is reasonable to stop the anti-resorptive or anabolic therapy when significant improvements are seen in bone mineral density. However, it has certain disadvantages. The major disadvantage is instrument is very large, not portable, and it is more expensive than peripheral technologies, and it uses ionizing radiation, though the radiation is very less. DEXA, the aerial bone mineral density, it does not detect the type of renal osteodystrophy in CKD patients, and it cannot evaluate the bone quality, but it can evaluate only the bone quantity. So the other limitations are the confounding effects of surrounding soft tissue, the bone artifacts caused by the osteoarthritis, degenerative disc, vertebral compression fracture, and aortic calcification, which are not that uncommon in CKD patients. And DEXA is a two-dimensional technique. So it cannot be used to measure the true volumetric bone mineral density and the bone size, or to separate a trabecular bone from a cortical bone. Thus, what happens is a large bone will yield a higher bone mineral density than a small bone, although the volumetric bone density would be the same. So in our patients, CKD will have a lower bone density than the general population, making the interpretation of DEXA more complicated due to the focal areas of osteosclerosis, extraskeletal calcifications, and the variable presence of osteomalacia. So as Jose sir has already told, we need the gold standard bone biopsy and dynamic histomorphometry, that is with tetracyclic labeling in our CKD patients.
Yeah,
especially
thank you.
4 and 5.
Thank you, John, very much. We have Professor Jacob George, who has a vast experience. Would you like to tell us about the head dynamic bone disease, which is we come across very often in dialysis patients, and the role of PTH and bone alkaline phosphatase? Jacob George.
Head dynamic bone disease is a major cause of low bone turnover disease in our population, and we often suspect it when on doing the tests like calcium phosphorus, alkaline phosphorus. We find that, and PTH, we find that the PTH levels are low and calcium levels are high, which is usually not very typical of CKD. And very often what we notice is that these patients are actually prone for vascular calcification. So several of times when we see the calcific uremic cartilopathy, dynamic bone disease is very often associated with this. And the characteristic feature, as I mentioned, was calcium levels are high and PTH levels are low. And one of the major causes of this happens to be increased calcium supplements, which we nephrologists, I should say, tend to overuse. We have been using a lot of calcium supplements as phosphate binders. And I think this is one of the major culprits behind the development of dynamic bone disease. And also, it's also known that patients with diabetes, which is a major cause of CKD in our population, diabetes also tends to have more of dynamic bone disease, and supposed to be probably due to decreased PTH release from the parathyroid gland by the low insulin levels. And also patients on CAPD, also the risk of dynamic bone disease is higher. Regarding the alkaline phosphatase, the bone-specific alkaline phosphatase is not something which is freely available in our place, and I think ordinary serum alkaline phosphatase also will give a good idea, unless the person has got some disease or underlying condition which falsely increases the serum alkaline phosphatase. Like the person has got a liver disease, then probably in such cases one could go for a bone-specific alkaline phosphatase. But if the liver functions are normal and there is no other reason why the serum alkaline phosphatase should be increased in a condition other than bone disease, I think serum alkaline phosphatase is also good enough.
Yeah, thank you very much, Jacob George. Binu Vendran, you have a lot of questions on dialysis. What is your approach for detecting osteoporosis in this group of patients? Binu, please.
Dialysis patient, we don't do routine blood tests for CKD except for calcium and phosphorus. We have stumbled upon adynamic bone disease on evaluation for three aspects. One, when the patient has anemia despite optimal erythropoietin therapy. Second, while evaluating for fractures. And third, with bone pains, extreme excessive bone pain. So these are the situations we have stumbled upon adynamic bone disease, and we have treated them by taking off all vitamin D analogs and calcium supplements sometimes, and we have resorted to teriparatide when the patient has got fracture. As bone osteoporosis, we have screened. We had a free screening test for all patients on dialysis, and incidentally, all of them were found to be osteoporotic. So I don't think it is of significance in our patients.
Right.
Thank you, Joseph, for that.
Thank you very much. Dr. Iqbal, you are dealing with a lot of post-transplant patients. Most of them are on steroids, I suppose, though there is some steroid-sparing regime. So how often do you come across osteoporosis in your post-transplant scenario?
Joseph, a fantastic talk. I enjoyed it. Thank you. Yeah, coming to osteoporosis and the post-transplant scenario, we should be careful in the high-risk group. If you're a diabetic, the post-menopausal women, elderly, more than 50, should be careful and see the basic parameters like calcium, phosphorus, as well as alkaline phosphatase and PTH, vitamin D levels. We come across a lot of hypophosphatemia in post-transplant, unlike they are in dialysis, there is hyperphosphatemia. So many a time we have to correct the phosphorus. Now it's very convenient because we get the supplements in the form of phosphorus, which was not earlier available. So to correct the phosphorus, with all this, in the high-end group, nowadays we do DEXA scan by high-risk group. High-risk group, we do DEXA scan and see as the T-score is less than 2.5, minus 2.5. Definitely, we treat that osteoporosis we come across if you look at osteoporosis, the high-risk group like diabetics, as I said, all these, and those who require some of them requires steroids for pulsing and for rejections. For a cell-mediated rejection, we might end up pulsing with solimedrol and methylprednisolone. So that group we have to be careful, and this come across that 20 to 30% having this osteoporosis. We treat it with now the denosumab is available. And it's easier, once in 6 months to 2 years can be given, can be once in 6 months, which is very convenient and less side effects. And you have to be careful with the calcium, and post-injection, we have to titrate the calcium levels. And the follow-up, definitely alendronate can be given once a week, which will stabilize things. So that's how it's treated. So basically look for the calcium, phosphorus, uric, and as well as the PTH levels. And we have to be careful about the adenoma also, parathyroid adenoma. Quite a few cases we picked up where PTH hasn't settled. Do an ultrasound, we see there is a potential for an adenoma mass, and look at the nuclear scan, it is confirmed. And once you take it off, that definitely cures the whole thing. So it's a great talk, Jose.
Thank you very much.
Thank you.
Yeah, post-transplant scenario, you have the advantage that the GFR is slightly elevated compared to, or more elevated than the CKD maintenance dialysis patients. Dr. Kishore, you have a very active ortho team or ortho program going on in your hospital. You get a call for a CKD patient with a fracture from the ortho department. So what is your advice and how do you manage that?
Great, sir. The profile of patients with fractures especially varies, especially in a CKD patient, stage 4 and stage 5. When compared to early stage CKD, also the normal patients, the normal renal functions. So they have probably fractures with lesser intensity trauma or even fragility fractures. So these patients have most of the time either they are bicarb is in the lower range. They are mostly acidotic. There are multiple contributing factors: vitamin D deficiency, hypophosphatemia, hypocalcemia, and of course hyperparathyroidism. And secondary, and those patients who are on dialysis for a long time can have tertiary hyperparathyroidism. And as age advances, as more and more CKD patients are elderly or the geriatric age group, age-related osteoporosis also contributes significantly. So the first at the early stages, CKD 3 and early stage, stage 4, we ensure that acidosis is well corrected, calcium and phosphorus levels are maintained in the range, and those patients with those osteoporosis probably are the early fragility fractures. We tend to do PTH earlier. Look for in those patients on dialysis, look for tertiary hyperparathyroidism, and even treat secondary hyperparathyroidism with cinacalcet. BMD measurements are commonly done in those patients in the replacement or those patients in early CKD stages. And denosumab, my experience with denosumab only in those patients CKD 3 or 4, and those patients who give a close watch on calcium, we are mostly weekly at the early couple of months at least. Also all the bone biopsy for is the gold standard. I have not much experience with bone biopsy in these patients. But then if we maintain these parameters, especially the phosphorus, keep the phosphorus low, try and monitor the PTH at least once in 6 months, keep the calcium well optimized, because these patients can have both hypo and hypercalcemia. We tend to overtreat, we tend to undertreat all these patients, ideally in the optimized range. And advise the patient, the orthopedician, regarding especially with the calcium phosphorus management, and of course other NSAIDs and all usage of the medications which are nephrotoxic.
Thank you very much, Kishore. Dr. Mangesh, can we extend our session by a few more minutes? 7 more minutes I need.
You can as much as you want.
Okay, thank you very much. So we have one question from Martin in the chat box. Let us see. That is it. Should we do a DEXA scan on a patient who present with fragility fracture? Is in the presence of a fragility fracture by itself an evidence of low T-score? Dr. Jose, would you like to answer that question?
Fragility fracture definitely by itself is a marker of osteoporosis, provided the only caveat is that you have to rule out a renal osteodystrophy and CKD and BD. Otherwise, it is a marker of osteoporosis. There is no need for a DEXA scan.
Yeah, thank you, Jose, very much. And we have Sadish Baran to tell us on preventive steps, monitoring of osteoporosis, and your personal experience on denosumab and teriparatide. Sadish, please.
Thank you, sir. I think Jose gave a brilliant talk, one of the best talks I've heard on osteoporosis and CKD. You can talk on osteoporosis, you can talk on CKD, but to talk of osteoporosis in CKD is not an easy task. You've done a very good talk. So about looking at risk factors of osteoporosis, like Jose said, the major problem is the confounding factors. You have CKD MBD, which completely destroys the basic concept of osteoporosis. And the CKD is almost impossible to diagnose. Even if you have one biopsy, I think it's difficult to diagnose. So that is one of the problems. But early CKD, that is stage 1 and stage 2, as well as post-transplant patients, I think the monitoring for osteoporosis should be done on a usual basis like you do for general population. Most of us, at least I was not doing DEXA scans till about recently. Only in the last 1 or 2 years, I have started doing DEXA scans on a regular basis. Osteoporosis was not on my radar as a very important topic, but now it has become more and more important. You see patients with fractures and what it can do to them in the short term and long term becomes important. So I think we should be monitoring calcium phosphorus, alkaline phosphatase in patients in that medium stage, that is CKD stage 3 onwards. In early stage, if you feel that the patient is problematic, I think we should be doing DEXA scans. Post-transplant, I think we should do a DEXA scan at least 1 year after a transplant and see whether they are, if they don't have any fractures. They have fractures, then definitely you know that it is osteoporosis. So it doesn't really happen. So that's how you monitor, a simple fact. Denosumab use also, I have used denosumab in early stage CKD as well as in transplant recipients. But it is too early for me to say whether effective or not. I mean, based on the evidence of DEXA scans and T-scores, T-score less than -1 also, I'm ready to use that regimen, osteoporotic regimen in the post-transplant as well as early CKD. But I don't use it in CKD, and I must say that it is also dangerous to use it in end-stage CKD. I had one patient post-transplant. He was on management somewhere else, and he had been given denosumab just 1 week before he came because he had a deceased donor transplant. And he was called and he came, and post-transplant 4th day, he developed severe leg pains and he was screaming in the bed. And we checked his serum calcium. It had been 9 at the time of admission. It was 3 at that time. Serum calcium 3, and it gave tons of calcium. And to come out of that, he took nearly 1 week. So I don't think we should be using denosumab in end-stage renal disease. Very dangerous drug, and severe hypocalcemia, long-standing hypocalcemia can result. This patient recovered faster, probably it was after transplant. So that is the experience of denosumab I have, and that's the thing. And again, thanks for a great talk, and thank you, sir.
Thank you, Sadish Baran, with also highlighting the point of hypocalcemia in denosumab treatment. Sometimes you come across that. Gokul Prasannan, you would like to add on any aspect of this osteoporotic talk? Anything, Gokul?
Thank you, Joe, sir. That is an excellent talk. I think most of the important points has already been discussed. I just have some queries to Joe, sir. Basically, sir, you told like denosumab, once we give, it is associated with a rebound increase in bone resorption. So is it like denosumab monotherapy is not advised, or should it be always preceded by bisphosphonates or teriparatide? And what is the approximate cost involved when we give this combination of teriparatide with denosumab? Thank you.
Denosumab cost is around it is marketed around 9,500 one shot Denbri. So 2 doses will be close to around 20,000. And regarding teriparatide, I'm not sure what the price is. Maybe Mangesh can tell about the price of teriparatide. And depends upon what the state of osteoporosis that you are dealing with initially. Like if it is something like not really low turnover, then probably start with teriparatide, follow up with the denosumab. So you build up bone, prevent bone resorption. That is a aim of treatment. Then denosumab, again, it is primarily used in CKD early stages, as Dr. Sadish told. So if you have severe osteoporosis and you are not a bit scared to use bisphosphonates, probably in you have contraindications like an esophageal problem or a peptic ulcer disease or a bad dental hygiene, then probably and those with a low GFR, then probably denosumab will be a better option. So you have to prevent bone resorption and give denosumab. But again, stage 5 definitely a very deadly drug. Apart from hypocalcemia, it also triggers vascular calcification. That is what the problem with the denosumab is.
Thank you very much, Jose and Gokul. With that makes us come to the end of the program. Thank Jose, which is an excellent presentation with a vast topic in a short time. All the active participation by the speaker pool. Thank you all very much for giving us this opportunity, the speaker pool for doing this. I should tell you that we are willing to do the same show anywhere in India online. And for anybody over India online, not physical. So you can consider to propagate your views.
Why don't we go international, sir?
Yeah, even international. Okay. We can go to Nepal. Why not? Okay. Jokes aside, thank you. We have taken a little more of your time. Thank you all. Thank you, Jose, very much. Thank you all the participants. And at last but least, the RPG, Mangesh, and Rohan and Deepu, very much. Thank you. Bye.
Thank
Good
you.
night.
Thank you so
Thank
much.
you.
Sir.
Thank you.